Move on to histopathology or dermatopathology, and we have Dr. Manoj Singh, who's the father of dermatopathology in India. He has done extensive work while he was at the AIMS, and now he continues to do in histopathology. He would project his own slides. He has a number of histopathology slides.
After a polymath like Dr. Malathi, is that many of the points which, except the pure histopathology, many of the points she's already covered. So I'll skip over them or, go very fast. Leprosy, as is the spectrum of disease, and tuberculoid to lepromatous with the borderline in between, and indeterminate when you can't make up, your mind about what you're talking about. So the Ridley-Jopling's classification was the first attempt to classify leprosy. And this was done by 4 criteria: clinical appearance, bacillary load, the histopathology appearance, and the lepromine reaction, which was an injected material, somewhat parallel to the tuberculosis test. And these were defined in 5 main categories. Tuberculoid, which was TT and BT. Borderline, which was BT, BB, and BL. And the lepromatous, which was BL and LL. So as you see, much overlap in these categories. And indeterminate, of course. And the reactional phase, which Dr. Malti has mentioned. And this is an attempt at making a slit smear. The ear lobe is a prime site for this, as leprosy, as you know, grows at a somewhat lower temperature than other bacilli. So, which is why more involvement of the ear, the nose, the genital areas, and so on, where the skin temperature is lower than in other parts. And this is what a slit smear looks like. You can see here these foam cells stuffed full of acid-fast bacilli. Acid-fast, as the name goes, is the acid-fast staining, carbol-fuchsin. And roughly, this is the bacillary index divided from 0 to 6, from negative to very numerous bacilli. And this is ideally performed in the oil immersion microscope. And this repeat. And as Dr. Malthi has already mentioned, reactional state in leprosy, where because of the immune system, or perhaps because or added by the treatment, the leprosy staging shifts from the tuberculoid side towards the borderline or the lepromatous side, or the other way around. And this has well-known clinical aspects and pathology aspects. I'll just like to mention briefly about these. Tuberculoid leprosy, clinically, as you have seen already, microscopically, in tuberculoid leprosy, classically, you have epithelioid cell granulomas. And these epithelioid cell granulomas are rimmed by variable color of lymphocytes. And traditionally, or if you are purely looking at the microscopy, TT actually has less lymphocytes than the BT, but it's a matter of putting the various criteria mentioned earlier. And this is a classic example of a BT leprosy. And as you can make out in the higher power, epithelioid cells forming an organized collection, the granuloma, and lymphocytes usually present on the outside, but also infiltrating into the amongst the granulomas also. And the classical place where you see them is around the blood vessels, around the appendages, and as is classically described in through the ears actually around the cutaneous nerves. And here you can also make out the appendages. This is the muscle, smooth muscle, erector pili, which is getting inflamed and destroyed partially, as are the nerves. And well, again, repeats of the same. Uh, and this is a cutaneous nerve twig present in the dermis, which is being involved by the inflammation and also destroyed. And as our mentor, from whom we learned a lot of leprosy pathology, Dr. Ashok Mukherjee, taught us that when you are screening, in the 70s and 80s, we used to get biopsies for release from treatment, and this nerve involvement was one of the things you had to look for. In fact, what he taught us was an aphorism. I don't know if it is mentioned in the books or not. He said, you do multiple sections, search for the nerves, and if you do not see nerves, then you are dealing with leprosy. The logic being that in leprosy, which has gone through some time, either by the disease process or after treatment, the nerves get destroyed. And this was, remember the time before immunohistochemistry, when you would do a S100 stain. Now we do an S100 stain, and you can make out small destroyed, very small nerve fibers. At that time, you could not. So it was difficult to make out. And the teaching was that if you do not see nerve twigs, consider leprosy. And as I had pointed out earlier, the muscle is also involved. And in fact, compared with the nerves, muscle is more of a diagnostic marker, because the muscle you can make out. And if a muscle is getting inflamed, destroyed, or surrounded by inflammation, it's easier to pick up than the nerve twigs are. So always look for the muscle. And in lepromatous leprosy, of course, uh, uh, in the low power, you see mixed inflammation. You see histiocytes, you see lymphocytes, and not well-defined granulomas. You see them scattered, and you see foam cells, as you can see here. And then this is again a very classic picture. You have a nerve which is surrounded by all this inflammation. Nerve which is surrounded by all this inflammation, the foam cells, the lymphocytes, and all. Nerve is not getting as destroyed as it would be in a tuberculoid leprosy. And again, the follicle, the appendages, sweat ducts, and follicles, which are surrounded by this inflammation. And please note the foam cells also. And on the acid-fast staining, you have variable amounts of acid-fast bacilli present inside the foam cells, as well as present, scattered amongst the inflammatory infiltrate. This is a counterpart of the HND. And this is one very beautiful foam cell stuffed full of acid-fast bacilli. And this, of course, is the acid-fast stain. And this is the fluorescent stain, which, perhaps the pickup rate here is better than here, because, at times the problem you have in acid-fast staining is that the background stain, the blue, is a little dark. So it becomes a little difficult to make out the red of the acid-fast bacilli versus the background stain. And that is where this dark background is perhaps better for screening. But of course, a matter of expense and having an appropriate microscope and so on. Lepra reaction, the only thing which I'd like to mention, Dr. Malathi has already mentioned this, whatever type of lepra reaction you're dealing with. The important thing to note in the histopathology is that at times, a lepromatous leprosy or a borderline lepromatous leprosy, when undergoing an upgrading reaction towards the tuberculoid or borderline end, very suddenly you will see within a week or 10 days, the bacilli will vanish because of the immune um, reaction going on. And it's very dramatic because at times you see that the bacilli have just vanished. Foam cells are present. And unless and until you have a good clinical description and clinical backup, you're going to keep wondering that you have foam cells, you have a suspicion of leprosy, but you do not have the bacilli. So there, a very careful search has to be done, especially if, of course, you're seeing the case for the first time. If it's a case on follow-up in the leprosy clinic or something, then you're a little stronger grounds. Uh, just to mention the fact that especially in ENL, in these reactional stages, you may have a considerable amount of paniculatus also, and you may or may not be able to make out vasculitis. There are cases which present as a deep paniculitis, which later turn out to be leprosy. Again, depending on the presentation and so on. Uh, Neuroid leprosy or nerve involvement, as you can make out, this is a nice nerve bundle which is inflamed, which is getting destroyed. And as you can make out the foam cells here, if you do uh, 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 acid fast stain in these, you will also be able to make out at times the acid fast bacilli present in the nerve substance or in the histiocytes in the nerve substance. And the same thing for the smooth muscles. Um, Lepromatous leprosy, very dense infiltration by the acid fast bacilli. And this is a similar, though not identical, to the picture you will have in a histoid leprosy. As I had mentioned, neurotic we'll totally skip the clinical uh, counterparts. Here you again have a nerve bundle which is getting inflamed. Nerve bundle with the classical wavy appearance of the nerve substance getting inflamed, getting destroyed here. And something which you do not often see, but is a part of the classical granulomatous reaction, necrosis in leprosy. Usually, it's much more common in tuberculosis, of course, but at times in leprosy, you may see necrotic reaction. So this, in fact, whether when it's present in the dermis, may look, in fact, like a tuberculoid leprosy, like a tuberculosis. And this is also a fairly common feature in nerve involvement because, as you know, the nerve has a perineurium, which is a fibrous capsule. And when you have a reaction in that particular patient, you have inflammation and you have sudden edema. So the nerve might get compressed, and inside the nerve capsule, you may have an area of necrosis. And this, as I was mentioning, earlier times we did not have this support, but now when you do an S100 in a suspicious case, this is of course a better preserved nerve. You may see in the dermis only a very few S100 positive fibers, showing that this was where the nerve twig was, which has been destroyed. So the S100 is a strong supportive stain for detecting leprosy, especially in a case where you don't have classical histopathology supporting it. Again, you're seeing here uh, preserved nerve here, destroyed nerve here, and this is the type of thing which you at times see in the dermis. Only this, you do not have the nerve twigs because they've been destroyed. And a nerve which has undergone edema inside the nerve and undergoing this is edema. And you can see that very few of the nerve twigs are preserved. The rest of it is necrosed, gone. Histoid leprosy is one of the variants on the lepromatous end, and called that because of the classical clinical presentation of hemispheric globules, and again this is classically described as actually spindle cells, not the macrophages stuffed full clear cytoplasm macrophages which stain highly positive with acid fast stain. These are more of spindle cells, as you can see here. Very few of the macrophages or the distended cells, these are spindle-like cells, and very high positivity for acid-fast staining. Thank you. That's my institute. Thank you.
Thank you.